camera attached. Fantastic. Okay, we'll make a start. Hi, good morning.
Hello.
My name is Michael, one of the doctors in the medical assistant unit.
Hello, Doctor.
Hi, before I begin, can I just get your full name and date of birth, please?
Yes, it's Jane Taylor. It's 18th November 1985.
Right, and how old does that make you this year?
37.
37. How may I address you?
Jane.
Jean. Right, Jean. What brings you to the hospital?
Well, I've been getting a bit concerned about my breathing. These last 5 days or so, I seem to be getting really short of breath, and it's affecting my work and what I do at home now.
Right, I see. And before these 5 days, were you known to be breathless?
No. I mean, before this happened, I've always quite been well going to work, getting on with my housework, looking after my family, but I'm struggling now.
Right, I'm sorry to hear that. And may I ask if it's gradually getting worse, or has it just been the same?
It's definitely getting worse than it was, yeah.
Right. If you were to give me a comparison before these 5 days and now, how much work were you able to do before?
Well, before it started, I was working 4 days a week at the bakery where I work, no problems at all. Coming home, doing my housework, my washing, ironing, cooking, no problems at all. I mean, I've never been one to sort of do a lot of exercise at the gym or anything like that, but I'm not one to sit still a lot either, so it's really affected me.
Right. And now, would you say you're breathless even at rest?
If I'm just sitting reading or watching the television, I'm not too bad. But if I'm talking a lot like this, even I can feel it now, it's affecting me now even.
Right. So even on slight activity, you would say you get breathless now?
Yeah.
Okay. How about your sleep? Is that affecting you?
Oh, that's awful. I mean, from the first day I noticed it, when I went to bed, I lay down and I had to get up straight away, I couldn't get my breath. And I started with 2 pillows, and then I actually used 3 pillows now, so I'm almost sitting up before I can actually breathe well enough to sleep.
Right. I'm really sorry to hear that. And just in regards to sleep, you mentioned waking up suddenly, short of breath.
It's like, if I lie down flat, I mean, I take a couple of breaths and then I can't breathe anymore, and it just frightens me. I have to sit up quickly.
I see. Have you got any cough at all?
No cough.
Chest pain or chest tightness?
No.
Any visual loss?
No.
Any coughs and colds?
No.
Fevers?
No.
Any loss of consciousness?
No.
No. How about tummy pains and aches?
No.
Any changes to your waterworks?
Well, yeah, I mean, that's strange. I don't know if it's got anything to do with it, but for the last maybe 3 days or so, although I'm drinking just as much as I normally do, I don't seem to be wanting to go for a wee so often. I'm not going to the toilet very often at all now.
I see. And when you do go, what colour is your urine?
It's really darker than normal.
I see. Okay. And have you felt your heart racing at all?
Yeah, that's another thing that happens, and that scares me as well. It's like I can almost feel it pounding in my chest, and that's really scary.
I see. And how about any swellings or any changes to your skin in your body?
Well, I noticed when I was putting my shoes on for the last couple of weeks actually, my ankles seem quite swollen, the straps are tight, and also down the bottom of my legs, around my calves, they're quite swollen as well.
Right, and this has only started in the last 5 days?
Well, my leg, I think my feet were swollen a little bit before that even, yeah.
And would you say the swelling's getting worse?
It seems to be, especially around my ankle.
Is it painful?
It's not painful, it sort of feels tender when I'm trying to put my shoes on, but it's not a pain that's there all the time.
I understand. Okay. So, Jean, are you aware of any medical conditions that you have?
Not now, no. I mean, I think normally I'm pretty healthy. I think I suffered all the things that I was going to suffer when I was a teenager. In my late teens, I seemed to spend most of my life opposite always to the GP with mostly problems with my joints, really, really painful joints. And I seem to get quite a lot of sore throats as well. But the GP, he was really good and kept treating it every time I went. And eventually, when I was about 19, 20, it stopped happening. And I've not had any recurrences since.
I see. Did it ever come to a finding of what caused that?
Nobody ever said anything to me, no.
Okay. Did they mention anything about your heart at all?
No.
Okay. Right. Do you have any allergies?
No, not that I know of, no.
Do you take any medications regularly?
No.
Other than the last few days, have you taken anything to try to alleviate your symptoms?
No, I really don't know what to do. I mean, I'm thinking maybe I need some sort of spray that I can't buy over the counter.
Are there any medical conditions you're aware of in your family?
Well, the only thing that my mum and dad both got high blood pressure, but that's all, I think,
Okay. Does asthma or atopy run in the family?
No. I'm wondering if that's what I've got actually, that, when I see people with asthma, it's a bit similar to how I'm struggling at the moment.
I understand. You mentioned that you work in a bakery.
Yeah.
Is that right?
About 4 days a week, that's all, but it's getting to be a real struggle now, and I can't keep up with everybody else. I don't feel like I'm pulling my weight properly.
I understand. And do you smoke at all?
No, I don't smoke.
Consume alcohol above the recommended limits?
No, I don't drink at all.
Good. Okay, any recent travels?
No, we love to go on holiday, but we can't afford it. Trying to save up, it's money on the side. Trying to get a seaside holiday away later.
That'd be lovely.
Yeah.
Any pets at home?
No.
Good. So, do you have any idea what might be going on, Jean?
Well, I'm wondering if it is asthma, maybe, I need one of those spray things that I see people using.
And what's your main concern? What's going on?
Well, mainly because I can't do my work and I can't look after my family, we need the money. We're not such a poor, but we need it to sort of live the life we live at the moment, so I'm quite concerned.
Right, okay. So, Jean, I've now taken history from you. Better understanding what's going on. Is there anything else that you want to tell me or ask me before I proceed to examine you?
No, I don't think so. No, thank you.
Great. So for the examination part of it, I will require your top to be off.
Okay.
And I'll be having a feel around and also have a listen around the chest region and the back region.
Okay.
And your legs as well.
Okay.
Okay?
Yeah.
But before I begin, I'll just be talking to the camera and also having a look around you. And I'll be explaining what I'm doing. Will that be fine?
That's fine, thank you.
Fantastic.
Yeah.
Okay, so I'll just put some notes on for the examination part. So, are there any questions that you have? Oh, okay. Just So I will start by looking at the bin and applications. Taking a look around, this will give me a good understanding of what will be going on. So it could be IV fluid stands, respiratory pots, oxygen, perhaps next to the patient, or inhalers. Okay, and also from this angle, you can see if the patient is struggling to breathe using accessory muscles, or if she's in any acute pain. And this view in the hospital, I'll be having access to all my monitors, which will be hooked up to an ECG machine, And vital signs should be regular results, SATs, blood pressure, which is attached to the cuff. So this will give me a good baseline understanding of how my patient is doing before I approach her. Okay. And then I'll start with hands. So Jean, please have a feel of your hands, please.
Yeah.
From here, I'm just feeling, okay, then making sure they're not falling clammy and they're warm. For this scenario, they're warm and well diffused. Okay, and then have a look in the nail beds, checking for peripheral stigmata of infective endocarditis. That could be splinter hemorrhages, and mark as well. Just check the capillary refill time. Okay. Tar staining and clubbing as well. So can you please do this for me? Put your fingernail beds together. Fantastic. Okay, and that's no clubbing. Good. And then flip the hands over, just check for any genuine lesions across the nose. Good. And then we'll move on to assess the patient's pulse. Now I'll let you feel both wrists for a good minute, and at the same time while I'm doing that, just have a quick look to see if the patient is having a high respiratory rate. Just have to have an understanding of it. Okay. Feel that. Maybe you can do 30 seconds and then multiply by 2. Over here I'm also assessing for regularity and strength of the pulse as well. And I'm checking both to see if there's any delays between both hands. Okay. I will then move on to check the patient's JVP. Okay, so the patient should always be lying on a 45-degree angle when assessing JVP. And what you can do is ask the patient just to look to the left. Jane, can you please look to the left for me? Okay, what you're looking for is just a pulse in the posterior triangle. And the way you calculate it is just from above the sternal notch. So here, if it's raised, it should be more than 45 centimeters. Normal should be 3 centimeters and under. And the way we describe this using millimeters of mercury, or centimeters of mercury, or centimeters of water, sorry, not mercury. Centimeters of water. So in this case, it's about 2 centimeters. But for the scenario, we'll say that she's got a raised JVP of 5 centimeters of water. Okay, you can look straight down, Jane. I'll then be assessing the patient's eyes. So now please get your glasses off. Please look up for me and look down for me. Thank you. Please open your mouth. Okay, let's take a tongue out for me and up. Fantastic, and close your mouth. So over there, I was checking the eyes for cyanosis or jaundice in the conjunctiva. And in the mouth, also around the eyes, you can check for signs of high cholesterol, central asthma, or arcus cornealis around the eyes, the iris. And in the mouth, checking for cyanosis, especially in the frenulum, and also for dental hygiene, and if there's any obstruction in the case of a patient having shortness of breath, that could be a cause of it. Okay, and then we'll move down into the neck region, and you can quickly check for tracheal deviation. Okay, there's no tracheal deviation. At this point in time, I'll ask the patient kindly to look at top so I can do a full assessment of the chest wall. For this case, I'll be doing both a cardiovascular and respiratory examination. I will check the cardiovascular in the anterior chest and respiratory section in the posterior chest. Okay. So the first thing we always do is inspect, check for any scars. In this case, there's no scars on the anterior chest wall, but you can see there is a midline abdominal scar, short one about 45 centimeters in the abdomen. Okay. The chest wall itself, just have a look to make sure there's no deformities, any pulsations, or any implants like ICDs. Okay, and make sure you look in the lateral chest wall as well, so we're not missing out on lateral thoracotomy scars. Okay. And once we're happy, you can move on. The next thing you can do is palpation. So always start with trying to find the apex beat. Usually it's located in the 5th intercostal space, slightly to the left of the mid-clavicular line. So tell your patient, I'll be trying to make a feel around to try to find your heartbeat. Okay. So try to locate it with 2 fingers, then 1 finger, try to be as precise as possible. In some patients, it's normal for you not to feel the apex beat, but I've located genes. Okay, and then you want to try to locate it by first finding the sternal notch that should correlate with the 2nd rib, and then counting down. So that's 3rd rib, it's 4th rib. Okay, and then that should be below the 5th rib. Then where your finger is placed, just draw a line in the clavicle. So that's to the left, I would say about 2 centimeters left of the mid-clavicle line at the 5th intercostal space, which is a perfectly normal spot for the apex beat to be felt in. Okay? Then while you're here, just have a feel for any thrills in the areas of the heart. And while you're here, you can just do a parasolic deep. So Jean, please breathe in and breathe out. And hold your breath for me. Good, just breathe normally again. So here will be indicated with right heart strain. Okay. So now we've done the palpation, we'll move on to auscultation. So again, auscultate the 4 areas of the heart, starting with the mitral area. If you can hear a murmur in this region, move into the bell and find the mitral region again and roll your patient to the left. Try to accentuate any murmurs you can hear. And that's fine. In fact, thank you. Next, you can hear the tricuspid region, pulmonary region, and the aortic region. Here, I'd like to ask the patient to sit forward for me. Breathe in, breathe out, hold your breath. Thank you. Breathe normally. And then while the patient's here, check right and carotid slowly. Breathe in, breathe out, hold your breath. Breathe normally. Thank you. You can lie back down. Okay, so that's auscultation done in the cardiovascular examination. And then, while you're here, we check the legs for any swelling and edema, which is very pertinent in this case, because she's complaining of leg swelling. So the way I like to check it is checking my bony prominence, so somewhat in the ankle is fine, in the malleolus, and if you do feel pitting, keep moving up until the pitting stops, and that's how we demarcate pitting edema. Go for both legs, check that. Be slightly gentle as it can be tender for patients. And let's say it goes up to here, so I would say it goes until below the level. Okay. So Jean, I'll be needing to examine your back as well.
Okay.
Would you mind just sitting up for me?
Yeah.
And just putting your feet dangling off the bed?
Okay.
Outside.
Yeah.
So for the respiratory examination, and then self-inspection again, ensure there's no scars, raised muscle wasting, any pulsations. Okay, and then we'll start by chest expansion. So I like to always check the apex first. So breathe in, breathe out, breathe normally. So you can see that my hands have a symmetrical rise. Okay. And for chest expansion in the actual chest region, the lung region, I would like to do 3 positions. So 1 above the line, 2 below. So especially breathe out, squeeze, and breathe in. Okay, do the same thing. Breathe out, breathe in. Good, and breathe out, and breathe in. Good. And if you can breathe normally, the chest expansion was equal and normal on both sides. Okay, I'll then move on to percussion. So plus apex. And I like to go left to right, left to right, left to right constantly, so I'm comparing both sides. Try to find space in between the ribs. and a long base as well. Good. After that, we'll move on to auscultation of the lung fluids. So, ask the patient to breathe in and out from their mouth every time the stethoscope touches them. Alright, Jean, every time the stethoscope makes contact with skin, you just take a deep breath in and out from the mouth.
Okay.
Thank you. Stop apex. Thank you. And breathe normally now. Okay, and then finally, I'll be looking for any sacral edema back here. So, ultimately, that will complete my cardiovascular and respiratory examination for this patient. So, thank you, patient. Thank you very much, Jean. And you may go back to your place. Thank you. So now we'll go through what the positive findings of the examination was. Okay. So, oh yes, my patient has kindly reminded me that I should check for just to be complete, just do an abdominal examination. So while you're there, you can do a quick abdominal palpation just to be complete, as some abdominal pain can mimic heart attacks or cardiovascular problems. So look at the patient's face to make sure you're not eliciting any signs of tenderness or you're superficially palpating. Yeah. Okay, check for any masses, tenderness, or body when you're doing this. Okay, feel the four quadrants and even the suprapubic region below, and the patient's not having that on. Thank you very much, Jean. Thank you. Great, so I just finished the history and examination of Jean. Before I proceed to ask some questions, I'll just give you some findings in the examination itself. Okay. So in terms of heart sounds, there was a mid-diastolic murmur, accentuated when I rolled her onto the left-hand side. Interestingly, there was also a loud P2 sound in the mitral area as well. Sorry, the loud P2 sound in the pulmonary area as well. So can anyone think of any findings that may support the heart sounds elicited by this patient? So it's a mid-diastolic murmur in the mitral region, accentuated when rolled to the left. Just feel free to type into the chat. I'll give it 20 or 30 seconds. Okay. No one? Okay, that's fine. That's fine. Okay. So essentially, that is indicating of mitral stenosis, which is a mid-diastolic murmur in the mitral area, and it's best when the patients roll to the left. Could anyone think of why this patient might have had mitral stenosis? Given her past clinical history, maybe? Okay. That's fine. Okay. So does anyone have any idea of how we can further investigate this patient? What easy bedside investigations can we do to get a better understanding of what's going on? Okay, that's fine. I think I'll just go through the slides. That way we will just go through it together, if that's okay. So, let me pull the slides up. Okay. So these were the findings from the patient. Okay. And these are some investigations that we can do. So a basic one will be an ECG, which is readily available, and will give you, if the patient's going through an MI or anything like that, will give you immediate findings. And also it can show you certain pathologies like right heart strain, for example, or hypertrophy inside the heart, or bundle branch blocks, perhaps. Okay. Secondly, another easy thing you can do is for suspecting heart failure in this case is a chest X-ray. There's a lot of findings in chest X-ray that points to heart failure. Okay. And then obviously we can do blood tests as well. So for this patient who's got clear signs of heart failure, given her apnea, paroxysmal nocturnal dyspnea, her swelling in her feet, and breathlessness, we'll definitely worry about heart failure. So we can do BNP, and we check inflammatory markers as well. Ultimately, she will need an echocardiogram because she mentioned having lots of joint pains and fevers when she was young. With the findings of mitral stenosis, that makes me very suspicious of could this be rheumatic fever, when she was a teenager. Even though it's resolved for many years, it could come back, leading to heart failure. Okay. Okay. So if you were to do a chest X-ray patient heart failure, there are some findings that are indicative of it. So I can only see the last two messages from Dr. Raza and your current messages, but nothing in between. So the last message I received was about 20 minutes ago. Were there more messages? Right, okay. No, I couldn't hear you as well. Right, okay. Okay. Definitely. So the heart sound was a mid-diastolic murmur, best heard in the mitral region. and it was accentuated when rolled to the left. Also, there was a loud P2 sound in the pulmonary region. Very welcome. So, yeah, so just going back to this case where I'm sure a lot of you would have suspected heart failure given the findings. It's important to do a chest x-ray because it's quick, it's cheap, and give you a lot of information about heart failure for this patient. That's acute heart failure, okay? So you can see in this image, there's a lot of signs here for heart failure. So general congestion is one of them. Curly V lines, you see this line just going across this field board over here. Okay, a widened mediastinum, and a widening of the carina as well. On the right hand side, you can see a double atrial border. So that's the atrial border over here, but it looks like a second notch, only because everything is just widened with a lot of blood not being able to pump up in the heart. Okay, an ECG, what's indicative of left atrial hypertrophy is a vivid P wave. So the P wave will have two peaks. And in this case, because she's got a valvular incompetency as well, yeah, this could indicate, it could be indicated by an ECG change, where you see vivid P waves. Okay.
Somebody saying they come here, but he's just dreaming.
So, yeah, so whoever came to a diagnosis of congestive heart failure secondary to mitral stenosis and pulmonary hypertension, well done to you. So pulmonary hypertension might not be so easily guessed in this case, but the findings that indicated pulmonary hypertension was a loud P2 sound in the pulmonary region. And it does make sense in this case as well, because if a patient has mitral stenosis, blood would have it would be very difficult for the blood to leave the left atrium into the left ventricle, eventually into the aorta. So there's a lot of backlog and backflow into the pulmonary system, which would increase the pressure of the pulmonary arteries, okay, and leading to pulmonary hypertension, okay. And this can cause further breathlessness as well, not just the heart failure. So pulmonary hypertension and heart failure are indicative of breathlessness, which is the main complaint. Okay. Ultimately, all this probably stemmed from her rheumatic heart disease when she was complaining of joint pains and fevers as a teenager. Okay. Normally, rheumatic fever leading to rheumatic heart disease is caused by group A streptococcus infections, and if it's not treated completely, it can progress and complicate into rheumatic fever. All right. So, someone with mitral stenosis and young, always keep it in mind. Rheumatic fever is a big cause. Good. So how do we manage these patients? Actually, how do we manage this patient? Can anyone come up with any ideas of how we would manage this patient? Please type in chat. Okay, I'll just go through it anyways. So, in terms of management, this patient, we're suspecting that she's had previous rheumatic fever, and there might be an element of valvular incompetency as well. Also, there's a lot of differentials there that we might be quite worried, right? I see, no worries. Thanks for clarifying, Dr. Raza. Yes, so if you are suspecting rheumatic fever, you can start prophylaxis antibiotics with penicillin V right away. But in this case, there is also a few differential diagnoses in mind that I will be worried about for this patient, wanting an inpatient stay so that I can clarify what's going on. Apart from just heart failure, with someone, a young lady with, shortness of breath and tachycardia, feeling like the heart is racing, I'll be worried about PE as well, pulmonary embolism. So I'll be going through my PE protocol to make sure I'm not missing out on PE, and possibly even starting anticoagulations early if I have a high index of suspicion. Okay? But then again, make sure you go through your guidelines to see if it's indicated at that point in time, or if a CTPA is indicated, or if it's a scan of the legs, because she's got leg swelling as well. Even though it's bilateral, unlike the VVT, you never know. Yeah. So there's a lot of differentials in mind, some quite serious. I'll definitely want her to stay as an inpatient. Okay. The other thing we can do is to control the symptoms of heart failure with furosemide or spironolactone, depending on her potassium levels. This will just give immediate relief to the patient. I think that would be quite good. Also, there are a few things you can give in acute heart failure. Make sure you sit the patient upright. You just help their breathing in general. Spironolactone is a good one. Furosemide as well. And of course, just to make sure we're following the protocol to check for heart failure, definitely stay with echocardiogram. Okay. We'll then want to check for infective endocarditis. That's a big one as well. Blood cultures are very important to check for infective endocarditis. Okay. And you can use a Duke's criteria if you've got suspicion to start antibiotics early as well for it, if you suspect it. Okay. And then once the echo is done, we'll be on the phone with cardiology to see if this patient is a candidate for surgery. Okay, because heart failure and valvular problems with rheumatic fever is an indication for surgery, but we'll need to speak to the cardiology team for it. And because we're suspecting pulmonary hypertension as well, which we can confirm with right heart catheterization, we need to give her advice on contraception, because being pregnant is a complete contraindication to pulmonary hypertension. Okay. So these are just different differentials when someone presents with breathlessness, different systems that can cause breathlessness, cardiovascular, respiratory, renal, anemia, or even someone sort of having a panic attack can lead to breathlessness, short of breath. Okay. These slides will be given to all of you guys, so you don't have to take any notes. Don't have to worry if you can't read everything in one go. You can read it in notes, and they're really big, helpful as well. Okay. So in terms of shortness of breath, we can quantify, or not quantify, we can localize it in terms of upper airway obstruction or if it's lower down. So if it's an upper airway obstruction, okay, in your trachea, or if it's in your larynx or your pharynx, it's most likely going to present as stridor, okay, because it's upper obstruction. When the person breathes in, it's going to sound like the person's choking. And then you go further down, you get your bronchioles, and people who smoke get mucus and pluggy, they get COPD, that's where it's affected, or asthma as well, where there's just a lot of inflammation in that area. Okay. You go further down again to the lung, the interstitium of the lung tissue, you get fibrosis in that area. And if you look at the vessels, you can think of things like PE, or pulmonary hypertension as well. And even in the lung tissue itself, you think of infections. So whether it's empyema, pneumonia, or if the patient has a tumor, depending on where the tumor is, it could be compressing on a certain structure in the lung, preventing the person from breathing more. So if you hear a monophonic wheeze, perhaps the wheeze start changing, could there be an obstruction just hitting that structure there, causing that same tone every time the person breathes in or out. Okay. Other causes of shortness of breath. And it's just a nice algorithm. splitting into acute and chronic causes of shortness of breath. Or we can think of some causes, and it's just a good way of just having a good idea of what can cause it and how we can think of things. Okay, I'll let you guys read this in your own time as well. What are some red flags for shortness of breath? The ones I can think of on the top of my head, definitely if someone's got B symptoms, so if someone's got hemolysis, night sweats, if someone's got stridor, immediately thinking of it, if someone's drooling, a quiet child that's drooling and short of breath, I'll be thinking of epicarditis, things like that, red flags. Immediately they will need to be escalated. So there are a lot of things you can check for in examination as well, to make sure we're not excluding red flags in examination. So clubbing, infective endocarditis, peripheral stigmata, like the ones we mentioned earlier, and all the things that we did just now to check for overload. Because in heart failure, it can cause just overload, especially in the right heart failure, it causes overload in your system. I definitely recommend you going on YouTube to listen to what the different heart sound like in the different valvular problems, so your aortic stenosis and regurg, mitral stenosis, mitral regurg, tricuspid, and pulmonary as well, just to have a good understanding of what they sound like. Okay. Causes of mitral stenosis, 4Cs, quite a good acronym to have in mind. Cool. So that concludes the first scenario. Okay. Are there any questions or any clarifications that you guys want with this scenario before we move on? Thank you. Okay. So great, I hope that was helpful. We're going to now bring in our second patient for the second scenario. So I will be doing the history taking, and then my colleague will be doing the physical examination, but I'll be talking through what he's doing as well. Is that all right? Okay, so now we will move on to the next bit. Should we just try that, because I'm just looking at the history, okay, and then you can. Hi, good afternoon. My name is Michael, one of the doctors in the admissions units. Before I begin, can I please get your name and date of birth?
It's Martin Fox, and the date of birth is 17/5/56, which makes me 66.
66 this year. Okay. And can I call you Martin?
Yep.
All right.
No problem with that.
Martin, what brings you to the hospital?
Well, over the last few weeks, or months, I've started getting pain in the lower legs, and it's got that bad now. I'm struggling to walk anywhere. I've feel such a weakness of doing anything, but the pain as well.
Right.
So it's got to the point where I'm hardly walking, I'm just shuffling around the house. And I can't even wear any slippers, it's getting that painful.
Right. Is it in both legs or just one?
It's in both legs.
Okay. And when you mentioned pain, is it there all the time? Or
Yeah, it's like a pins and needles at times, and like a numbing pain.
Okay.
The whole lot. And it's just constant.
Right. And can you tell me where this pain exactly in the legs?
It started really around the ankles, going back, it's got to be about 3 months. I just noticed that I was starting not moving so well, and again, this pain is just coming on gradually, and then it just works. Oh, and it's from the knee down, basically.
From the knee down. And does it cover the back of your legs as well?
Yeah.
Okay, how about the soles of your feet?
Yeah, they're painful as well.
Right.
That's why I'm struggling to walk, and even putting slippers on, just tightness around your feet, I can feel that.
Have you noticed any ulcers or cuts to your feet?
I haven't noticed no changes at all, no.
No. Good, good. Okay, let's talk more about the pain or the pins and needles then, okay? Mentioned that it started 3 months ago, gradually getting worse.
Yeah.
Right, and how would you describe it in further detail?
It's just there, it's a constant, feels like a constant pressure, and just numbness, you can't really describe it.
Right, numbness, okay.
Yeah.
And does this pain spread anywhere else?
I've had it occasionally just down my forearm into my left hand. More the pins and needles type thing. Whether it's connected or not, I don't know, but a couple of times.
Into the fingers as well, or is it just your arm?
It's mainly the arm, but it has gone to my fingers.
Right, and it's just on the left arm, not the right?
Yeah, it's only on the left and not the right.
Okay. Have you noticed any weakness in your limbs?
I've got definite weakness in my legs. I'm not walking anywhere near like what it used to do. Normally I'm fit and active and getting around all over the place, but now I'm just shuffling around the house.
Right. Have you noticed any weakness in your eyebrows, your lips?
No.
Any drooping of your eyelids, perhaps?
I haven't noticed them. Nobody said.
Any changes in your voice, or anyone noticed any changes in your voice?
Again, nobody said anything, so I don't think so.
Any changes to your vision?
No.
Any loss of consciousness?
No.
Any fevers?
No, I think the last thing I had was a cold about 2 years ago. I've been fine until then.
Okay. Any chest pains?
No.
Right. Any tummy pains?
I do feel a bit bloated at times. Now on the left-hand side, it feels like I've had a full meal.
Right.
When I've had a full meal, so very, very tight. I don't seem to want to have a meal, for quite a time. I don't feel like wanting to eat again for quite a time.
Right.
So yeah, I have noticed that. I forgot about that, but thinking about it, yeah.
Okay. And how's your waterworks enhanced?
That's fine. Yeah, I have no problem with that.
And how are bowel movements?
Again, seems to be fine.
Okay. Any back pain?
I do get twinges every now and again, but I put that down to my work, so disability, so obviously, over the years, it's generally wear and tear.
Right, and apart from your left arm and your legs, has there been any loss of sensation, any part of your body, especially in the groin region?
No, I haven't noticed any there. No.
Good. Does this numbness or tingling, does it come on and off, or is it constantly there?
It's constantly there.
It's constantly there. Okay. Have you noticed that anything might make it worse?
I've tried to, I don't know, I've tried standing up and sitting up and moving around and raising your legs and all sorts of things to try and find if anything's happening, but still.
There's a medical history in disease and drugs.
Yes, of course. So what I'm going through now is Socrates, which is just getting a better understanding of his presenting complaints. Normally after the Socrates, which includes systemic review, I'll then ask the patient about his past medical history, drug history, family history, social history, and then I'll complete the ICE. So that's just the structure that I think will be most complete. But definitely we'll get to past medical history and medication history as well in a bit. Yeah, thank you. Yeah. So, Martin, what was that?
Movement.
Yes, movement. Yeah. Do you notice that the pain alleviates when you hang your feet off the bed, perhaps. Some people have that.
I've tried, but no, nothing's, at the moment, nothing's really doing it. But I'm trying to actually do too much movement because how much pain and if anything happens, you know, if I fall over or something like that. At the moment, I haven't fell over, so, yeah.
Great. Okay. Right. So now I'm just asking you about your health in general. Are you aware of any medical conditions?
Well, yeah, I've got diabetes, and I've got a tablet which I use for something thin. I can't.
So metformin?
I think that's it, yeah. I'm supposed to take that, but I must admit I'm terrible at taking it. I remember every now and again it might be 3 or 4 days in between, or even a week or whatever. And so I am terrible at remembering to take that. So I'm on that, and then I'm on a statin as well.
Statin. So you've got diabetes and high cholesterol.
Yeah.
How long have you had diabetes for?
10 years, I think, is when I
We have the question. Looking at muscle atrophy and stress in your life.
Let us know muscle atrophy and disturbance in data. Yeah, definitely. So that will be covered in social history, which we'll get to as well. We'll be asking about his job and family support, also how he's getting along with just his daily movement, and he needs any support from that point of view as well. Definitely muscle atrophy is important to ask. So that's a good question to ask during the systemic review as well. So that I would definitely ask about if he's noticed any muscle wasting. But then again, if a patient has got significant muscle atrophy during the examination, it's definitely easily picked up on as well. So don't worry. Good questions, thank you. Right, so diabetes for 10 years.
Yeah.
Have you seen regular follow-ups for it?
I do go occasionally.
Yeah, did it do your feet care and your eye care?
Just a general quick look over, that's all I get. Seems to be like about every 2 years or something. It isn't a regular occurrence.
Right, and you check your blood glucose regularly? No. Okay. Do you have any allergies, Martin?
Again, not where I know. No.
And in your family, are you aware of any conditions that are significant?
The only one had been mother, she had bowel cancer. And the rest in the family, there's no obvious medical history, but any problems, it's the normal flus, coughs and colds and things like that.
Sorry to hear that.
But no, there's no medical, there's no genuine things.
Okay. Right. And what do you do for work, Martin?
I'm a self-employed builder. So of course, loss of my legs is a major thing. I'm worrying about it like that because obviously I'm letting customers down, but also I'm letting my family down because if I'm not working, I'm not earning money.
Yeah. That's completely understandable. And do you live in a house or a flat?
Yeah, it's a house.
Is it stairs in it?
There is stairs, but the last couple of weeks I haven't been even going upstairs because the pain and the effort to try to get up is, I don't think it's worth it. By the time I got up there and thinking, well, I'm better off staying downstairs.
Right, and is anyone supporting you in some home?
Yeah, my wife is, so that's right.
Okay, that's good. And do you smoke?
I do occasionally, it is only very occasionally, sort of like 2 or 3 cigarettes a month, something like that, just in a social thing when I'm out. It isn't a regular habit, no.
Right, okay. And do you drink alcohol above the recommended limits?
Unfortunately, yes. I started off years ago just having a few glasses of whiskey at night to unwind. I still do that now. It must have been going on for 8 to 10 years.
Right.
The problem is now I've normally finished the bottle by the end of the night.
About a bottle of whiskey per night?
Yeah.
And are you seeing anyone trying to stop it or trying to cut down?
I've never even considered it. It's just a thing that happens. It's just the way it's been.
Do you realize that you might need alcohol sometimes to wake up and get started in the day?
Sometimes I'm a bit slow, but yeah. But then obviously the day unfolds and that's it. And of course, can't wait to get back at night, have a sit down and have a read.
And has anyone asked you or tried convincing you to slow down and stop drinking before?
No, not really.
Not really. Okay.
The wife has a few jobs every now and again, but she's on mine, so that's it. Yeah.
I see. I see. Okay. So what are you most concerned about, Martin?
Well, obviously, lossing your limbs, I would have if I would be able to walk. I've never known anything like this at all.
What do you think is going on?
I don't know. I just haven't got a clue that I'm here. It seems strange how it's been the last 3 months and just building up and building up. It's got to the point where I can't do anything.
Okay. So I think I've asked all the questions I wanted to.
Yeah.
Is there anything I've missed out on that you want to fill me in?
The only thing I've tried regular paracetamol and aspirin and things like that to try and get rid of it. But they don't normally work for me anyhow, but I don't normally take anything else. So just thought I'd try it to see if it helps.
Yeah. Okay.
Apart from that, no, everything's as far as I think of.
Great. So what we'll do, Martin, is do some bedside investigations.
Yeah.
Okay. I'll take some blood from you, possibly just get some pressures from your ankles and also from your arms. Okay.
Yeah.
And then I'll also be doing examination, or my colleague will be doing examination on you.
Yeah.
Okay. And then we'll further discuss what we can do to see what's going on.
Oh, thank you. Yeah.
Is that all right? Is that all right, Martin? So, Dr. Hasib will now do the examination, but we apologize for some technical difficulties with the goggles, so you won't be able to see his point of view. But hopefully, just the view from where you can see him now, I'll just be talking through what he's doing, and it will be, helpful just to have a look as well. So it should still be fun.
Yesterday, the follow was the main camera.
Yeah.
Did you use the main camera to follow around?
Hello. So I'm just doing a quick examination of features you've done, and then I will detail the logical examination. Okay. Thank you so much.
So, you say you will see what?
Dr. Hasib is just doing a cardiorespiratory examination on his patient. So just doing an abdominal examination, especially in this patient with ascites or with abdominal extension, you want to check for ascites.
Still there.
Okay. And you bring your address from there. All right. That's right. Okay.
Yeah.
I see it is now checking for any sensation
Let's
loss.
start with examination of your eyes. Cleaning the examination first. Yeah. Look at this tip.
We do the cranial examination first. So this is just H test checking for cranial nerve 2. Checking for any eye movement
Okay, that's fine.
deficits.
So could you smile for me, please? This is for the facial nerve. Okay. So from okay, that's fine. Close your eyes for me. Can you hear this?
Yes. Yes.
Okay.
Yeah.
Why did we should do from that?
So you check down cranial nerve 8, ideally with tuning 4, but just check the general hearing is intact.
Okay, that's fine. So now we're going to further sensory examination. Okay. Now you touch this tip on your fingers, and every time then you can feel the motor.
Yes. Yes.
So Dr. Hasid is now checking for
Yes.
fine touch sensation in the dermatomal distributions in the upper lip.
Yes. 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 Yes.
Let's do the same for the next.
Yeah, we'll be doing the same for the lower limbs as well.
Keep your eyes closed. Can you feel this?
No. 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 Very slight. Very slight. Slight. Yeah. Slight. Yeah. I feel like more. Yeah. Yeah.
Press it over here.
Yeah.
Here.
Yeah. Yeah.
So the patient does not have sensations below the shin.
Yeah.
Okay.
So, yeah, in lower limbs bilaterally, there's no sensation of fine touch below the level of the shins. Between the shin and the knees, there are slight improvements in sensation, and above the knees and in upper limbs, there's no loss of sensation.
So I want to do this one here. You can feel the pain a lot.
So now, Dr. Hasid is
Yes.
using the pinprick
Yes.
test to
Yes.
check
Yeah.
for pain sensation and loss in pain sensation in the upper and lower limbs in the
Yes.
dermatomal
Yes.
distribution.
Yes. 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 Yes.
Let's do the same for the So we can be for the lower limbs. Let's
No. 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 Very slide.
okay.
Slide. 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 More. More. Yeah. Yeah.
Hold here.
Yeah.
Here,
Yes.
yes, here,
Yes.
okay. Here,
Yes.
okay. Here,
Yes.
here,
Yes.
okay. So the big sensations are lost middle-range area.
Yeah, so there's the same lump sensation in both fine touch and pinprick sensations.
Let's move on to the bottom now. I need you to lift up this right hand now, please. Okay, and down. Not that far. Okay, and down now. Hold these fingers wrong. Do it yourself. Do it again. Okay, that's fine. So the ball is not on the upper limbs. That's good. All the lower limbs now.
So bilateral in the upper limbs, there's MRC, flat left parallel.
Breathe in close one. Okay. And move your ankle. Can you lift it up? Move it down. Okay. Bend it down. This one go. Okay, fine. So, push my hand down. Okay. This one. All right. Now, can you bend your knee, please? Push my hand away. Towards yourself. Push my hand away. Towards yourself. Try to lift up your thigh. This one. Okay. Try to push it down. Now the other one. This one. So the power above the knee and knee joints is normal. But yes, the power is diminished of 4 out of 5 in the ankle and in the toes.
So the power in the knees bilaterally above the knees is normal. However, in the ankles, especially on plantar flexion and dorsiflexion, there's reduced power for other 5 MRC.
I'm going to do some further just to check the coordination, okay? Yeah. Touch my finger with your finger and touch it to your nose now.
And now let's see, it's just assessing cerebral function and coordination.
Okay, the other one. Okay, that's fine. I want you to rub his shin of yours. Rub this hair of yours on the shin.
So the heel shin test, check for coordination
Yeah.
in the lower limbs.
The other one. So there's no problem with the patient's coordination. Everything is fine. Would you be fine to walk? Do a walk assessment.
I can try, but I can't think very far.
If you are not comfortable with it, it's fine.
Yeah.
Yeah.
Oh.
Walk straight towards me.
Can you refresh? So, in the direction. This one?
Okay. Close your eyes. Without feeling that you've got to lose the balance, yeah?
Yeah.
Okay, yeah. And then we sit again. So this was the raw works test. And the gait assessment. Yeah, there you go. So thank you so much for your time. And then now we'll do some investigations. And yeah, we'll come back to you, okay?
So great. So that was the end of the examination. Thank you, Dr. Abbasi. So before the discussion, so anyone has an idea what may be going on with this patient? Anyone?
Thanks, everyone.
Thanks. Anyone have any ideas of what may be going on? I'll just move it to the next portion. Give me 2 seconds. Okay, so essentially this patient who's got long-standing diabetes with very poor compliance with medication and poor follow-up as well. He drinks a lot of alcohol, about 1 bottle of whiskey per night, which is not good. So in this case, everyone is probably thinking about a main differential diagnosis of peripheral neuropathy secondary to uncontrolled diabetes, which can present this glove and stocking manner of sensory loss, which this patient has presented with. Although it's quite obvious, or it may seem quite obvious what the patient is going through, it's important to ask for red flag questions to make sure we're not missing out on life-threatening problems and conditions like Corda-Equina syndrome, perhaps, which may present with lower limb weakness and pain. But we can ask important red flag questions to make sure that we're not missing out, especially in our history, and we can elicit some of them in examination as well. Okay. So, ideally, we want to check our patient's gait, because a gait will give us a lot of information about pathology. For example, if someone has a broad-based gait or a narrow stepping gait, and think of different ataxias or even different cerebellar pathologies associated with that. And in someone with diabetic neuropathy, you'll find that they'll be a lot more cautious where they're stepping because they're not able to have that peripheral sensation of where they actually are. So even the proprioception is disturbed in peripheral neuropathy. So assessing gait will be quite important. But along with that, some bedside investigations can be done, like blood. So definitely checking on HbA1c and even blood glucose at the moment to check how bad his diabetes actually is at the moment. You can do urine tests, check for ketones, possible DKA. And then finally, you want to refer for nerve conduction studies if we're suspecting peripheral neuropathy, as it can be objectively quantified of how bad this neuropathy actually is. Okay. Other stuff you can do, ECG, ABPI, if you're suspecting fortification in the limbs. And you can check for sensation around the perianal region, which is quite good to rule out Corda-Equina. Not rule out, sorry, just to have a better understanding if this could be Corda-Equina. Additionally, Corda-Equina loss of bladder control is a big complaint, so you can do a pre and post void bladder scan, which is helpful. Okay, so how would we manage a patient with diabetic peripheral neuropathy? You first have to manage expectations, so tell them, although we can't completely cure it, intervention is important now to slow down disease progress. Often you'll need MDTs, so neurologists, physiotherapists, podiatrists and orthotists to deal with the foot and hygiene control, and also, of course, diabetic specialists as well to control the blood sugars. This patient definitely needs to be on insulin. So when it comes to weakness in limbs, we can take two approaches, or two main approaches to find out where the lesion is, or what the pathology is lying behind it. So one way we can do an anatomical approach. So we look down brain all the way down to muscle and try to locate the pathology. Or we can go through a surgical filter, so thinking about different ways in which we can get weaknesses like infections or trauma, etc. So we'll be looking at that in a little bit more detail. So with the anatomical approach, it'll go from upper to lower motor neuron, upper being the brain, brainstem, spinal cord, and the lower from the anterior horn cell onwards. And these are just some causes listed under each heading. could be causing the weakness in the limbs. The surgical filter is quite good. This gives you just different causes of limb weakness in a acronym, vitamin C, D, so that's quite helpful. You can have a read at your own time. Again, these slides will be given to you guys. Okay. Upper and lower motor neuron lesions, the way it's distinguished is just based on anatomy. So anything in the brain stem, spinal cords, all the way until the anterior horn cells will be upper motor neuron lesion. Anything from the anterior horn cells all the way to the muscles and nerves in that area will be all lower motor neuron lesion. Good thing is that the presentation will be distinguished based on tone reflex, articulations, and clearness as well. So the way I like to remember it is upper motor neuron, everything is up or increased. The lower motor neuron, vice versa, everything decreased or down. Okay, so we look at this table here. Upper motor neuron, everything's increased. And in lower motor neuron, the opposites. And that way it just gives a good idea of roughly where the pathology is. Are we dealing with something in the brain or something in the peripheral nerves? Okay. Am I still clear? Or okay. So then this is just an algorithm on upper motor neuron lesions. So you can even distribute it even to how much of the body is affected. Hemiparesis, just half side, quadriparesis, all limbs affected. Well, these are distributions. So someone with MS, for example, classically, the lesions will be spread out in space and time. So they come up 2 years with remission, and then come back again, but this time here, the presentation will be their legs rather than their back, so it's spread out in space and time. It's quite bizarre, but we know that for MS, it's actually in the brain itself, but it's spread out in a different manner, as in you would find in stroke, for example, upper motor neuron problem. Okay. So, you can't see the screen share. Is that better? Is that on now? Sorry, that might have been my fault. Sure. Okay, great. Sorry about that. All right, same again with low motor neuron. So you can have just a distribution on where is the distribution. So you can look anatomically, and it's just quite a good algorithm to try to break that down and see what the causes are, more specific to each anatomical region of where it's been affected. Okay, but I'll let you guys read this in your own time as well. It's quite a good algorithm to go through. So just going through the key points again. Upper and motor neuron lesions. It's quite good because it gives you quite a general idea of where the lesion is, just based on very easily picked up signs from examination. Okay, and time course is very helpful because it can indicate whether something's acute, like stroke, where the definition of a stroke is acute neurological deficits. So if it's not acute, it's not a stroke, right? Or if it's something that's spread out over long periods of time, thinking of something like MS, right? And of course, just being very thorough with the neurological examination is essential to find out. I mean, a lot of people would think that just get a scan, but you'll be amazed at how much you can find just through good examination. Right. Lastly, acquired acquired syndrome, something that's easily missed out on because the presentation is quite vague. But make sure you ask the red flag questions and check for the proper tests, the bedside investigations that will give you peace of mind that you can rule out acquired acquired, such as your pre and post void bladder scans, checking for perianal sensation loss, asking about back pain. These are simple things to do and can give you peace of mind when you think about acquired acquired. Okay, and whether this person really needs MRI spine, or if you want to vet it to a radiologist, at least ask these red flag questions so that they will do the scan for you. Okay. So these are just some questions to ask in Product Finder. So again, these are just good questions to ask to rule out different things, whether it's Guillain-Barré, ask about vision loss, ask about recent diarrhea, even that could complicate Guillain-Barré from Campylobacter infections, right? And multiple sclerosis, if that patient is, female, she's in mid-30s perhaps, all these things will point to different pathologies. So there are a lot of causes for limb weakness, limb pain. Fortunately for this patient, straightforward peripheral neuropathy. But I guess the take-home message for this is that even if it may seem straightforward, there's always a lot of things we can ask and elicit during examination to make sure we're not missing out on red flags. Okay, so that brings us to the end of this session. Thank you very much for listening. Is there any questions that anyone wants to ask? Any questions? Just comment in the chat below. No? Wonderful. So thank you all so much for your time. Thank you for tuning in. And hopefully, it was helpful. So, have a great rest of the day, everyone.